I'm 𝐸𝐴 𝐂𝐵, CEO at the Harley Street Health Centre. Today we are delighted to be welcoming Dr. Sunil Patel, Consultant Respiratory Physician at the Harley Street Clinic. So good to see you, Dr. Patel. Thank you so much for joining us.
Thanks for having me. Yeah, pleasure to be here.
Great. So my first question, I know we've got a topic today, but let's just get to know you a little bit. Why respiratory medicine?
So, it's a very unique specialty. It covers a lot of areas of acute medicine, general medicine, as well as specialty medicine within the area of respiratory health. It's got a lot of breadth in practical procedures, inpatient, outpatient care, for example, and it links very well with other specialties such as rheumatology, cardiology and oncology in certain areas as well. So it's very fascinating, very interesting time for respiratory medicine.
And of course, post-pandemic, wow, that must have been a time for you guys.
Yeah, so of course with COVID-19 being a primary respiratory illness and respiratory virus, respiratory medicine was certainly at the forefront of that alongside intensive care and respiratory intensive care. And we really did learn about so much more about respiratory viruses and how they impact not only respiratory health but longer term outcomes for patients with severe infections. Yeah.
So today we're talking about persistent cough, a cough that doesn't go away. And when you proposed that topic, I was really, really happy because I know this is an issue that affects a lot of people. I think it's also an issue that some people tend to wait a long time before seeking medical advice. And I thought it would be really, really helpful to talk about what are the common reasons someone might have a persistent cough, what can trigger that, what are the sort of things that you don't really need to worry about too much, what's more serious, and yeah, when is the time to come and see you, So I thought it would be really, really helpful to do that today.
Great, and I'm happy to discuss that. So we'll get straight into it. So, what is a persistent cough, one might say first. So there are lots of varied definitions about that, but what we call an acute cough is someone who didn't have a cough before and has had a cough for less than 3 weeks. So classically, those patients will be someone who's had a viral infection, has had a constellation of symptoms, but with an associated cough, and usually that's a self-resolving illness and the cough goes away. The persistent cough is slightly more tricky. One would say therefore it's more than 3 weeks, but the true definition of a chronic cough or a persistent chronic cough is one that's past 8 weeks. And that's really where we start to think about potential other causes outside of things like infection, for example. Now, primary care and general practitioners are very skilled at dealing with patients who have a worrying cough, and that is really something that I want to be clear about. And someone who has an acute cough or a new cough, someone who's never had these issues before. And there are certain cases where we need to act quicker and get patients seen in primary care and maybe even within secondary care. So those patients tend to be patients above 40, any smoking history in the background.
Even if they've quit?
Correct. I think it's very important to stress that your smoking history is important. You don't need to be an active smoker. You could have smoked 10, 20 years ago, for example. But if you're over 40 with a smoking history, it's very important to get a cough that can't be explained checked out from your general practitioner. The second thing is our certain associated symptoms. We tend to worry about patients who have associated chest pain, unexplained breathlessness, and certainly patients who are coughing up mucus with blood and or have lost weight alongside those symptoms. And those are really patients that need to be seen soon and expedited care into primary care and on to a respiratory physician in secondary care.
Wow, that's a really, really helpful summary. So let's say I'm 35, I'm not, but let's say I wish. And I had a virus of some kind, right? I felt ill over Christmas, caught something, and I'm still coughing. So all my other symptoms have gone. What could be the reason for that?
Yeah, so it's a very commonly presented problem to respiratory medicine. So if we go backwards and think about a virus classically causing a cold-like illness causes a degree of inflammation, and classically that inflammation can start anywhere from the upper respiratory tract, so your nose and through to your throat, and also affect the lower respiratory tract, which is beneath that level and into the lung itself. And essentially there is a degree of inflammation, and all along the linings of your lung are areas and nerves that are prone to inflammation, and sometimes the sensitivity to a cough is lower. So someone who was not inclined to have a cough previously suddenly starts coughing a lot after such an illness. And what we see is that the cold, or the runny nose, the congestion, the headaches, the muscle aches, disappears. And what you're left with is someone who has a cough that is either dry, can be minimally productive, or has a new set of symptoms away from the cold itself. And that is classically what worries a patient who was fit and well before, who had no respiratory problems, and they therefore seek care with their GP and on to a specialist after that. What I would say is, if you have had a cough and you're worried about that cough being persistent, never doubt going to see a healthcare professional. Always seek attention for the reasons we discussed earlier, because some of those other risks might not be apparent to you, but would be apparent to your healthcare professional and allow onward referral. So what happens when the cough persists after the cold? It's the cold-like illness. That can vary. It can be anywhere between a few weeks and sometimes a couple of months. And it is vitally important that if it does persist past 8 weeks, that we see you, and therefore we would call someone who's had a chronic cough.
Thank you so much. I think so many of our patients fall into that category.
Yeah.
And I think it's so important, as you say, to just make sure the other risk factors aren't present. Peace of mind, if anything else.
Of course.
Because I think being stressed about your cough is just going to worsen it.
Yeah, absolutely. I think, and on that note, so we know from studies within the community and general practice and primary care, we know that somewhere in the order of 1 to 2% of patients in the community have a chronic cough.
Wow.
Which is
a large number.
Which is a very high proportion, and that's probably underreported. There are studies that say that it's underreported, probably because of the way we code how patients come in and code their illnesses. So if you're dealing with 1 or 2%, or up to 2 in 100 who have a potential chronic cough, the burden of the impact and the burden in healthcare is huge, because not all of those patients will have the same cause for the chronic cough. So it does keep general practitioners and respiratory physicians occupied, but we'd rather see the patients earlier on rather than have a late presentation of an issue.
No, of course. One of the areas I read about in preparation for this, I do a little bit of preparation for it, is post-viral asthma. This idea that there are adults who may not have been asthmatic as children, develop asthma later in life triggered by a viral infection. Is that?
Yeah, it's an interesting area. It's essentially, to separate that out, that we spoke about a virus being an inflammatory problem. There's a degree of inflammation in the body that occurs when you have a virus. That's how viruses work, and your body produces inflammation to attempt to get rid of the said virus. And that is certainly true with COVID-19, for example. But there are lots of other respiratory viruses which have a similar effect on the body and degree of inflammation. Now, people who have asthma is a chronic inflammation of the airways and the respiratory tract. They are slightly at a higher degree of risk for developing an exacerbation of their asthma because of a virus. Now, your question was about someone who didn't have asthma and then suddenly develops asthma-like symptoms. But if you think about what a virus does, it causes inflammation. It can cause overproduction of mucus and therefore narrowing in the airways of the lung, which gives you symptoms that look and sound and feel like asthma: wheeze, chest tightness, productive cough, and sometimes shortness of breath. So it doesn't mean that you have asthma, because asthma is a diagnosis that needs lots of different aspects of medicine before you label someone as asthmatic. Lung function, for example, a longer term history, a history of exposures. So having simply a virus and asthma-like symptoms doesn't mean you have asthma. And it's very important to delineate that out and see a respiratory physician or initially a primary care healthcare professional to decide whether this is an acute viral illness causing asthma-like symptoms, or it's someone who has asthma made worse by a virus. And those are very distinct physical appearances of a patient.
That's really interesting. So if you were going to give a list of red flags, things where, otherwise, say, a relatively healthy person should absolutely, quick as anything, get themselves to a doctor, what would those red flags be?
Yeah, I think that's a really important point to discuss again. So we spoke about some aspects. So a patient who has a smoking history and a new unexplained cough, I think that's very important to clear first and foremost. So the other associated risk factors would be a patient above 40 with a smoking risk, and any patient that is coughing up blood, either in or mixed in with mucus or fresh blood in itself, is an absolute indication to go and see a doctor immediately. And there are very clear national guidelines that exist about these patients being referred quickly into a secondary care service. There are associated symptoms as well, such as chest pain that you never had before and can't be explained by any other more trivial, let's say, causes, needs immediate attention. And that is true in a general respect outside respiratory medicine. If you have unexplained chest pain, you should go and see acute medical attention as soon as you can. An unexplained shortness of breath or difficulty in breathing with those symptoms should absolutely prompt healthcare referral. Weight loss that you can't explain. Some patients are very active, trying to be healthy, exercise and eat better, but sometimes that can mask a longer term problem which you may just feel is due to diet and exercise. But sometimes if you can't explain the weight loss, you should absolutely go and see a healthcare professional. So to summarise, it would be a patient with a smoking history above 40, any history of previous respiratory illnesses and particularly associated symptoms of chest pain, shortness of breath, or coughing up blood with weight loss.
Thank you. And speaking of smokers, people talk about a smoker's cough, as in it's a cough that they have because they smoke. Is there a way to distinguish between that and what you're talking about?
Yeah, I think it's a generally used term in the public to describe that. I think it's a fair description. So essentially, smoking is, as easy as it is to understand, is an inhalation of a foreign substance which is not meant to be in the lung, and therefore it can be perceived as an inflammatory issue. So you inhale the smoke, it causes a degree of inflammation in the airways and damage to the airways in the long term. And one of the sort of compensatory effects of that is to produce mucus in the airways. So classically, a long-term smoker would have a cough which is very loud in nature, would cough up a degree of mucus and be able to clear it, and then therefore if there's lots of mucus in the airways, bacteria and other microbes and other infective agents can get into the mucus, cause a significant chest infection. So the smokers tend to be at a higher risk, and because they're also at higher risk of chronic lung disease as a result of smoking itself. So we tend to label that as a bronchitis or a chronic bronchitis because of the duration in which it's apparent in the patient.
Thank you. So I guess we would be remiss without talking about early signs of lung cancer. You've already gone over red flags. Would you say there's a lot of crossover in the red flags you described?
Absolutely, and that forms the basis of how we refer patients into secondary care quickly and promptly. Multiple specialties have pathways into secondary care to screen out and investigate potential cancer quickly, and those are classically termed 2-week wait pathways, where a primary care physician would see a patient, satisfy a criteria for a potential cancer in any organ system, and refer that patient quickly into a service in secondary care or private care, and however else a secondary care physician can see that patient. So there is a lot of crossover with those symptoms. So most of those red flags are described to feed and to tease out conditions that are time sensitive, cancer being one of them. And it's not entirely the case that just because you have 2 or 3 red flags that you will end up developing cancer, but your risk is of course higher. You may have a severe chest infection that needs input and follow-up, and therefore you're put into the pathway that allows that to happen. But the symptoms we spoke about, chest pain, unexplained shortness of breath, weight loss and production of blood in the cough, there are certainly symptoms that are associated with a lung cancer, and that's why we refer patients quickly.
And they'd be right on that pathway.
Absolutely.
If they presented
Absolutely.
with those.
Yeah.
That's really reassuring, I'm sure, for
Yeah.
for our listeners.
Yeah.
So, lastly, I thought let's just talk about optimizing lung function. Yeah, if you are somebody who is prone to getting, I don't know, shortness of breath when you're sick, or just struggling a little bit with your breathing, what would your top 3 tips be?
Yeah, you probably have more than to
more than
condense
3,
it into
yeah.
3, but
You can, as many as you need.
Essentially, it's about the common sense approach is often the best, and actually we know certain things that are unequivocally going to affect respiratory health in a negative way. So most people will be very clear in the fact that smoking of any description for any duration of any amount is a risk to respiratory health. And then what is associated with that is effects on other systems like your heart, for example, and it increases risk of heart attacks, increases risk of strokes, and complicates issues with people who have diabetes, for example. So there are lots of downstream effects that we think about outside of the lung. So smoking cessation should be offered to every patient that enters any medical facility, regardless of why they came in there, because it has a huge impact on the patient, and it's probably the single best thing you can do for a patient to stop smoking to benefit their health. It also has a huge economical impact. There's a big problem with the effects it has on respiratory health. The degree of healthcare that is used after due to smoking related illnesses is certainly not insignificant. So stopping smoking would be my number one thing to suggest to patients, and for healthcare professionals to suggest to their patients. There's lots of community services to refer patients into. A lot of them are free, and a lot of them have very good longer term support. Both you can use that online and use community services together. And it's very much a tailored, bespoke package to the patient. There is no one way to stop smoking, and it is proven that if you facilitate that, it's more likely that the patient will stop smoking rather than someone just wakes up one day and decides to stop smoking. So smoking cessation, number one by far. The second thing is, if patients do have respiratory conditions, so let's take asthma for example, there are certain things that we know that can help people with asthma. Now asthma has a spectrum. You can have a very mild degree of asthma, or you can have a more severe end where you have frequent what we call exacerbations in the symptoms. Now it's about tailoring that again to the patient, so avoiding things that will predispose your risk to infection. Eat well, rest, look after exercise and diet and those things together. Those are just, again, what I call the common sense approach to any health issue. But it's about complying with the medicine you've been asked to take. So taking the medicine, there's no surprise that if you use it correctly, it is likely to provide you a benefit. But it's also about recognizing when those don't work. Just because you're on a medicine, there's no guarantee that it's going to completely help and reverse your problem. You may need it adjusted and monitored and reviewed at periods of time. So it's important to be vigilant of symptoms in patients who have known respiratory conditions. That applies to any other conditions. So patients who have chronic obstructive pulmonary disease, or COPD, classically associated with long-term smoking. We know that aspects such as exercise, smoking cessation as well, help improve outcomes for patients in the sense that they're less likely to go to the hospital with a problem because of their smoking-related lung disease, and patients like it. They can do something in the community, they can engage with other patients in a similar position to themselves, and it is shown that it improves their functional ability. So engaging in exercise around all of the medical aspects is a very important thing to do.
That's great. Do you find that these things are reversible? So if somebody has been a long-term smoker, let's say, is struggling a little bit, that by stopping smoking and doing all of the things that you've described, that they can improve their lung function long-term?
Yeah, so if you drew a graph of everyone as they get older and plotted a general descriptor of lung function, everyone's lung function will go down in time, okay? But that doesn't mean you get ill from respiratory illness. It will just slowly decline, unfortunately, like most other body systems, but you will be fine from a symptoms perspective. Now, there's other things that will accelerate that. So if you have smoked for a long time and a significant amount, your lung function has been shown to decline to an extent. Now, that doesn't mean you can't sort of halt that and steer yourself back on track, but there is data and evidence to suggest that you will not quite return back to the level of lung function as someone who never smoked for the same amount of time. But you may have lower lung function, but your degree of symptoms may be absent as well. But it's very important to labour that the sooner you stop smoking, the better it is for your longer term health. Logic would say if you've smoked for 60 years of your life and in your 80s, for example, it's more difficult to claw back any sort of respiratory health, and that's certainly not achievable or realistic. So you would have to optimize that patient for what they have in front of you. So it's a real stress from us to the patient to say, the sooner you stop smoking, the sooner we can improve the respiratory health and your longer term outcomes as well.
Dr. Patel, this has been so illuminating, so helpful. Thank you so much for being with us today.
Very welcome. Yeah, thank you for having me.
Thank you everybody for listening.
Thank you.